Testosterone levels decline as men age, and other hormones often fall out of optimal balance too. Restoring the youthful levels of testosterone and other hormones can help to support the overall well-being and good health. Most men know testosterone is important for health and performance, but many don't know that maintaining healthy levels of other hormones like estrogen and DHEA is also important. Supplementation with zinc and chrysin can help men to maintain healthy hormonal balance, while a blend of pomegranate and cacao seed extracts support healthy, free and total testosterone levels. This protocol can help you to learn about comprehensive hormone restoration and how it can support your health when combined with proper medical care, a healthy diet, adequate sleep and plenty of exercise. Maintaining balanced hormone levels is essential to men's health overall. Unfortunately, men's testosterone levels decline with age. Most men know that testosterone is important for sexual function, but research indicates that normal testosterone levels are associated with the preservation of cognitive function, a healthy body weight, metabolic activity, and more. In addition, low testosterone levels have been associated with increased mortality. Testosterone levels are affected by several other hormones and enzymes, such as dehydroepiandrosterone, or DHEA, which is a precursor to testosterone and estrogen. Aromatase, which is an enzyme that converts testosterone into estrogen. And sex hormone binding globulin, a glycoprotein that binds to testosterone. Given the complex interplay among the various hormones, binding proteins, and several other variables, thorough lab testing is essential before initiating a testosterone replacement therapy. Several natural interventions such as pomegranate and cacao seed extracts, nettle root and zinc can help to support healthy testosterone levels as well, and these should be part of a comprehensive hormone balancing regime for men. Low testosterone occurs with increasing age, with increased body fat or obesity, with chronic diseases like diabetes and acute illness, with poor nutrition status and poor liver function, and with oxidative damage. Low testosterone levels can happen from declining levels of steroid hormone precursors like DHEA, with certain medications, with diseases of the testicles like primary hypogonadism, and with diseases involving the pituitary and or the hypothalamus like secondary hypogonadism. Comprehensive hormone testing is necessary to obtain an accurate overview of your hormone balance. Both free and total testosterone levels are important, but so is the level of estrogen and the ratio of testosterone to estradiol. Other hormones like DHEA, as well as proteins that influence hormone bioavailability, like sex hormone binding globulin, should also be tested. Hormone levels will vary widely between men, so it's important to repeat the tests periodically to identify trends over time. Consideration should also be given to other symptoms or disease conditions that one is experiencing. Only after comprehensive testing and thorough clinical evaluation can one decide whether hormone replacement therapy is a good choice. Testosterone replacement therapy should be embarked upon with the guidance of a qualified healthcare professional experienced in men's hormone restoration and balance. At this time, scientific literature does not support the association between high testosterone levels and an increased risk of prostate cancer. However, the use of testosterone restoration by men at high risk for, or who have had, prostate cancer remains very controversial. All men should discuss the risk and the benefit of testosterone restoration with a qualified healthcare provider before initiating on testosterone treatment, including with respect to the prostate health. Aside from hormone replacement therapy and diet and lifestyle changes to promote metabolic health and a healthy body weight, there's natural approaches to support testosterone levels and healthy male hormone balance. A blend of pomegranate and cacao seed extracts have been shown to promote testosterone production in clinical and lab studies, and also to improve testosterone-related parameters such as grip strength. Zinc is essential for many aspects of male reproductive function, from testosterone metabolism to sperm motility. As a precursor to testosterone, adequate DHEA levels are required for healthy testosterone production. DHEA levels tend to decline with age. Protodiazine, an active ingredient in Tribulus terrestris, can convert to DHEA in the body. It has a reputation as an aphrodisiac, and animal studies seem to confirm its ability to boost sexual function. The bioflavonoid chrysin naturally inhibits aromatase, and thus it can help to reduce the conversion of testosterone into estrogen. Its bioavailability can be boosted by taking it with piperine, a black pepper extract. Luteolin is a flavonoid with protective antioxidant effects, and has been shown to be a natural inhibitor of aromatase and also to promote testosterone production by additional mechanisms. Lignans in nettle root can prevent sex hormone binding globulin from binding to testosterone, and this can boost free testosterone levels. Nettle root is often used to relieve benign prostatic hyperplasia symptoms. Mira puma can improve sexual performance in men who have a loss of libido. The significance of testosterone for male sexual function is well known. Substantial research has clarified the critical role that testosterone plays not only in maintaining youthful sexual vitality, but also neurological health, bone health, depression, metabolic disease, as well as inducing fat loss in those who are unable to reduce body weight with diet and exercise alone. Observational studies have demonstrated low testosterone in men is associated with metabolic syndrome, type 2 diabetes, and cardiovascular disease. Moreover, low testosterone has been associated with a substantial increase in mortality. Similarly, a low testosterone to estradiol ratio has been associated with increased cardiovascular mortality. Other studies have shown testosterone treatment in men with low testosterone levels is associated with reduced mortality. Ongoing clinical trials will provide further evidence as to the effects of testosterone therapy in men with low testosterone levels with respect to hard clinical outcomes, such as the time to major adverse cardiovascular events. One such ongoing trial is the larger TRAVERSE trial, which is examining the effects of testosterone therapy versus placebo in 6,000 men with low testosterone levels. This trial is expected to be completed in June 2022. Restoring testosterone to youthful ranges in middle-aged obese men resulted in an increase in insulin sensitivity, as well as a reduction in total cholesterol, fat mass, waist circumference, and pro-inflammatory cytokines that are associated with atherosclerosis, diabetes, and metabolic syndrome. However, because a bidirectional relationship exists between low testosterone and metabolic disease, such as diabetes and obesity, it's imperative that these conditions be addressed also. In men with low levels of testosterone therapy also significantly improves erectile function. DHEA is a hormone produced from cholesterol, and it then follows one of two pathways, both involving a two-step enzymatic conversion to yield either estrogen or testosterone. Thus, levels of DHEA can have a role in determining the levels of estrogen and testosterone, although DHEA alone is seldom enough to sufficiently restore testosterone levels in aging men, and it may also promote an increase in estrogen. One of the most important factors that affects testosterone levels and the ratio between testosterone and estrogen is the aromatase enzyme. Aromatase is produced in many locations in the body, including adipose tissue, the gonads, breast tissue, the brain, the skin, and the bone. Aromatase converts testosterone to estrogen, further depleting the free testosterone levels and increasing estrogen levels. Increased aromatase activity has been shown in aging, obesity, hyperthyroidism, and with various malignancies. Sex hormone binding globulin is a protein and it's produced in the liver, and it binds to both testosterone and estrogen, and it regulates hormone bioavailability. Most testosterone circulating in the bloodstream is bound to either sex hormone binding globulin or to albumin. Only a small fraction is unbound or free. Testosterone binds more tightly to sex hormone binding globulin than to albumin. Consequently, only albumin-bound testosterone and free testosterone constitute the bioavailable forms of testosterone, which are accessible to target the tissues and carry out their actions of the essential hormone. Thus, the bioavailability of testosterone is influenced by the level of sex hormone binding globulin. However, low levels of sex hormone binding globulin may contribute to low total testosterone measurements in obesity and diabetes. Excess liver adiposity related to metabolic disease, known as non-alcoholic fatty liver disease, commonly occurs in conjunction with both obesity and diabetes, and has been shown to play a role in the lower levels of sex hormone binding globulin seen in these conditions. Aging men experience both an elevation in sex hormone binding globulin production and an increase in aromatase activity. The net result is a decrease in total and free testosterone levels and an increase in the ratio of estrogen to testosterone. The vicious cycle of low testosterone and obesity has been described as the hypogonadal obesity cycle. Obesity is also associated with a decrease in luteinizing hormone levels. Luteinizing hormone promotes the production of testosterone in the testes. Low testosterone levels contribute to increased abdominal fat, which in turn leads to increased aromatase activity. This enhances the conversion of testosterone to estrogen, which further reduces the testosterone and increases the tendency towards abdominal fat. Certain genetics also play a role in the development of low testosterone levels in the overweight and obese men. Research has shown that various interventions with the intended goal of weight loss in obese individuals also increase testosterone levels, specifically in obese men with type 2 diabetes. 5 years after having bariatric surgery, free testosterone levels increased by 48% in men who had surgery, compared with a decrease of 2% in men having medical therapy without surgery. Increases in total testosterone have also been observed in obese men 6 months after bariatric surgery. Simply losing weight by following a low-calorie diet and maintaining the weight loss also has been shown to increase the free testosterone level in obese men, with the increase maintained up to a year later. Much like obesity, diabetes has been shown to have a bi-directional relationship with low testosterone levels. Hypogonadism is more commonly found in those with the disease, while treatment of hypogonadism with testosterone helps to prevent the progression of prediabetes to diabetes. In a population of 103 diabetic men, 1/3 were found to have low testosterone levels. Both free and total testosterone have been shown to be lower in men with diabetes. The use of certain medications, including glucocorticoids, opioids, gonadotropin-releasing hormone agonists, which are commonly used for the treatment of prostate cancer, and androgens for performance enhancement, can lead to reduced testosterone levels by interrupting pathways that are critical to testosterone production. Low testosterone levels have been shown to persist for up to 2 years or more after the cessation of anabolic steroid misuse. Critical and chronic illness can lead to low testosterone levels. This includes acute events such as head trauma, a heart attack, or surgery, or chronic illness such as chronic kidney or lung disease and cirrhosis of the liver. The liver produces sex hormone binding globulin and albumin, and it converts androgens to estrogen and other testosterone metabolites, and it inactivates and removes estrogen among other activities which are related to hormone metabolism. Decreases in liver function, including liver fat accumulation or liver cancer, can exacerbate the hormonal imbalances and compromise the healthy testosterone levels. The exact cause of age-related reduction in testosterone levels is not entirely known. It's probably the result of a combination of factors, including the increase in body fat, the oxidative damage to tissues responsible for the production of testosterone, the reduction in testicular testosterone synthesis, declining levels of precursor molecules like DHEA and pregnenolone, an elevation in sex hormone binding globulin production, and nutritional status and liver function. The consequences of declining testosterone levels are striking and a factor in many of the degenerative changes and the chronic diseases that are seen with increasing age. Testosterone affects fat cell metabolism and fat loss in several ways, inhibiting fat storage by blocking an enzyme called lipoprotein lipase that's necessary for the uptake of fat into the body's fat cells, stimulating fat burning by increasing the number of specific receptors on the fat cell membranes that release stored fat, increasing insulin sensitivity, enhancing growth of muscle fibers, and decreasing fat deposits. All of these effects promote lean body mass and reduce the fat mass. Placebo-controlled trials have demonstrated both significant increases in lean body mass and decreases in fat mass after varying courses of testosterone treatment in older men. In these studies, the greatest favorable changes in body composition were seen in the participants with a low baseline testosterone level who received testosterone therapy for 12 months or longer. Emergent evidence suggests that maintaining youthful testosterone levels can help aging men to avert a variety of inflammation-mediated diseases, such as atherosclerosis and arthritis. By powerfully suppressing the activity of an enzyme called 5-lipoxygenase, testosterone calms a fundamental pro-inflammatory pathway that's involved in the synthesis of signaling molecules known as leukotrienes. The leukotrienes are derivatives of the pro-inflammatory omega-6 fatty acid arachidonic acid, and these molecules underlie much of the inflammatory development of asthma and bronchitis, and they play a role in the pathology of cardiovascular disease and diabetes. In a study involving 184 men with low testosterone levels, 18 weeks of testosterone replacement therapy suppressed markers of inflammation, including interleukin-1 beta, tumor necrosis factor alpha, and C-reactive protein. Moreover, when compared with men who received a placebo, the men receiving testosterone replacement exhibited significant decreases in body weight, body mass index, and waist circumference. The reduction in waist circumference indicates that testosterone reduces fat accumulation around the trunk of the body. This is particularly important since central fat mass is strongly associated with increased susceptibility to inflammatory diseases and mortality. Testosterone therapy has been shown to decrease weight and improve measures of health in men with low testosterone levels. In a non-randomized registry study of 471 obese men with hypogonadism, patients elected to receive either testosterone undecanoate injections or no therapy. After up to 11 years, the weight decreased an average of 23 kgs, or about 20% of the body weight, in the testosterone group versus a 6 kg, or about 6% of body weight in the placebo group. Testosterone treatment was also associated with a decrease in waist circumference of 13 centimeters, compared with an increase of 6 centimeters in the control group. Finally, the testosterone may have had positive effects on other health outcomes. In the control group, heart attacks occurred in 28% and stroke in 27% of the men. No heart attacks or strokes were reported in the testosterone group. Deaths were also reported at a significantly lower rate in those who received testosterone compared with those who didn't. Importantly, these findings of the study have not yet been published in a peer-reviewed journal at this time. Bone integrity rests upon a balance between bone formation and resorption, which is controlled by multiple factors, including levels of estrogen and testosterone. In a clinical trial, testosterone increased bone mineral density in elderly men. Low testosterone levels also may contribute to the development of sarcopenia, the loss of muscle mass and strength, which is commonly seen with increasing age and in chronic kidney or liver disease. Sarcopenia contributes to physical disability, mortality, and morbidity. Testosterone supplementation has been shown to have a positive effect on muscle metabolism and strength and increase lean body mass in older men. Further studies are needed to determine the role of low testosterone levels and its relationship to sarcopenia and age-related frailty. Key to aging well is an optimistic outlook on life and the ability to engage in social and physical activity. However, low levels of testosterone have been associated with depression and other psychological disorders. To make matters worse for aging men, many conventional antidepressant medications suppress libido. Some experts suggest testosterone therapy might reduce the need for antidepressant medications entirely. Furthermore, testosterone treatment often increases the feelings of well-being. Cognition and alertness are also governed in part by testosterone's effect on the central nervous system. Low testosterone levels have been shown to correlate with lower scores on various psychometric tests, and similar effects have been reported in men who are undergoing androgen or male hormone deprivation therapy for prostate cancer. Testosterone also acts as an endogenous neuroprotective agent able to support neuron integrity against a variety of toxic insults, including oxidative stress. In addition, testosterone has been shown to reduce beta-amyloid accumulation, a pathophysiological factor in Alzheimer's disease. Testosterone improves neuron survival in brain regions that are vulnerable to neurodegenerative disease. This might explain the association of low testosterone levels in men with neurodegenerative diseases. Studies demonstrate testosterone loss occurred 5 to 10 years prior to Alzheimer's disease, suggesting a low testosterone is an important risk factor for Alzheimer's disease. In a clinical study of 36 men recently diagnosed with Alzheimer's disease, intramuscular testosterone treatment with 200 milligrams every 2 weeks for up to 1 year was associated with improvements in both overall cognitive ability as well as critical visual spatial function. Testosterone also has been linked to metabolic function. Specifically, studies have found low testosterone in men correlates with increased risk of metabolic syndrome, which is a state of metabolic dysregulation that's characterized by excess abdominal fat, high blood sugar and cholesterol, and high blood pressure that increases the risk of cardiovascular disease. One clinical study found that men with low testosterone levels were twice as insulin resistant as their counterparts with normal testosterone levels, and 90% met the criteria for metabolic syndrome, threefold higher than those with the normal testosterone level. There also appears to be an inverse relationship between low testosterone levels and diabetes in men. Men with diabetes have lower testosterone levels compared with men without a history of diabetes. The third National Health and Nutritional Survey of 1,413 men showed that men initially ranked in the lowest one-third with respect to either free or bioavailable testosterone, were approximately 4 times more likely to have diabetes compared with those ranked in the top one-third, after the researchers adjusted the results for age, race, ethnicity, and body weight. Several interventional studies have found that testosterone therapy can improve body composition. It can ameliorate abnormal glucose and insulin metabolism, and it can lower total cholesterol levels. Among men with metabolic syndrome and low testosterone levels, testosterone therapy has been reported to reduce waist circumference and improve glucose and insulin metabolism. In men with type 2 diabetes and low testosterone levels, similar metabolic benefit has been observed with testosterone therapy. However, these improvements might not manifest in men with metabolic syndrome and/or diabetes, who do not have low testosterone levels. Moreover, it's difficult to disentangle the origins of these metabolic improvements in response to the testosterone therapy. These responses might be indirect. Weight loss and improvements in body composition that result from increased well-being and motivation following testosterone restoration might contribute to the observed metabolic improvement. Regardless, men who have low testosterone levels and/or type 2 diabetes might stand to benefit from testosterone restoration. Importantly, a 2016 meta-analysis of data from 32 studies reported the metabolic benefit of testosterone restoration might be time-dependent. This analysis found the metabolic benefit, apparent after 2 years of testosterone treatment, was less pronounced after only 1 year. In other words, men might need to adhere to testosterone therapy for 2 years or more to realize the marked improvements in the metabolic parameters. Observational research has provided evidence for an association between low testosterone levels and increased risk of cardiovascular disease and mortality. Administration of testosterone appears to be correlated with improvements in several cardiovascular risk factors, including atherogenic lipid profiles, insulin resistance, obesity, and propensity to clot. A 2018 meta-analysis of 37 observational studies, including over 43,000 men, followed for an average of 6.4 years, found that low endogenous testosterone levels predicted the overall and the cardiovascular mortality and the cardiovascular morbidity. In addition, research has identified an association between low testosterone levels and increased incidence of cardiovascular events in men with existing cardiovascular disease. For instance, in a longitudinal study of 930 men with coronary heart disease referred for diagnostic angiography, those with the lower testosterone levels have almost double the absolute rate of all-cause mortality over a 7-year period. Additionally, in men with atherosclerotic cardiovascular disease, low testosterone levels were associated with a higher risk of cardiovascular disease-related hospitalization and adverse outcomes, while in men with heart failure, low testosterone was associated with increased all-cause mortality, myocardial damage, and lower exercise capacity. Although data available as of late 2021 suggests an association between low testosterone levels and cardiovascular disease, these types of correlations are prone to residual confounding. Additionally, there's research that's not yet shown the relationship. Large prospective interventional trials are still needed to clarify whether the testosterone therapy in men with low testosterone levels will improve their outcomes. One such study in a population of the US male veterans with low testosterone and multiple comorbidities found that over a mean follow-up of 4.3 years, the use of transdermal or intramuscular testosterone was not associated with the risk of a composite cardiovascular outcome in men without existing cardiovascular disease. However, in those with existing cardiovascular disease, transdermal testosterone treatment was associated with a lower risk. The TRAVERSE trial is assessing the efficacy of topical applied testosterone gel compared with placebo in 6,000 hypogonadal men. This trial's primary endpoint is time to major adverse cardiovascular endpoints, including heart attack, stroke, or death due to cardiovascular cause. The study estimates the completion timeline to be June 2022. Androgens are essential for the proper growth and development of the prostate. Later in life, androgen signaling, in particular activation of the androgen receptor by the potent androgen DHT, influences the prostate cell proliferation and the functions of the prostate. In addition, aromatization of androgens to estrogens locally in the prostate tissue might contribute to prostate growth. These findings, which are undergoing continued refinement in active research, suggest the balance between testosterone and estrogen might be important for maintaining prostate health. Comprehensive testing, along with a thorough assessment of signs, symptoms, and overall metabolic health, are essential in determining hormonal imbalances in aging men. The so-called normal level of testosterone in older men might reflect population averages. However, it's believed most aging men would prefer not to accept the loss of youthful vigor versus normal. Instead, it's suggested that an optimal level for all men would approximate the upper one-third of the reference range used for the younger men, and that testosterone replacement therapy should aim to restore the hormone levels to that range. Example, free testosterone of 15 to 25 picograms per milliliter, a total testosterone of 600 to 900 nanograms per deciliter, and an estradiol level of 20 to 40 picograms per milliliter. When measuring testosterone levels, it's critical to determine the level of both free and total testosterone to understand the underlying biological phenomena that might be contributing to the androgen deficiency symptoms. It's also important to remember that blood levels of both free and total testosterone vary widely among individuals, making it difficult to establish a general baseline on which to prescribe a standardized treatment protocol. However, levels are quite consistent with individuals, and thus it's important that men have multiple tests over time to determine trends and individual thresholds for the treatment. Consideration should also be given to other symptoms or disease conditions that one is experiencing. During the initial testing, it's also imperative to test estrogen levels. Many of the unwanted effects of male hormone imbalance might be caused by an elevated estrogen level relative to low testosterone levels. Because of difficulties with equipment standardization and inter-laboratory variability, it's recommended that physicians consistently use the same local laboratories to gain the familiarity with the accuracy, precision, and definition of the normal values for the assays offered in their communities. A study published in the Journal of the American Medical Association measured blood estradiol in 501 men with chronic heart failure, compared with men in a balanced estrogen quintile, the men in the highest quintile, with serum estradiol levels of 37.4 picograms per milliliter or greater, were significantly more likely to die. Those in the lowest estradiol quintile, with levels of under 12.9 picograms per milliliter, had a 317% increased death risk compared to the balanced group. The men in the balanced quintile had the fewest deaths, and they had serum estradiol levels between 21 and 30 picograms per milliliter. This is within the ideal range. A study published in 2021 evaluated levels of testosterone estradiol and the ratio in over 1,109 men in the US. The men were then categorized into quartiles based on their levels of the aforementioned hormonal variables. The men whose testosterone was in the lowest quartile had about 1.7 times greater risk than those whose testosterone was in the upper quartile. Similarly, men with a testosterone to estradiol ratio of less than 10 had about 1.3 times greater risk of dying from cardiovascular disease than men with the higher testosterone estradiol ratio. It suggested that most men strive to maintain a ratio of between 23 and 40. An epidemic problem that is observed in aging men is insufficient free testosterone that's less than 15 to 25 picograms per mil in serum, when accompanied by excess estradiol of over 40 picograms per milliliter. This can signal excess aromatase enzyme activity. Testosterone replacement therapy requires a physician's prescription and supervision. If a man opts for testosterone therapy, available orally or as an injection, a subcutaneous implant, a topical cream, a gel, or a skin patch, he should keep several facts and precautions in mind. Hormone replacement should not be initiated without comprehensive lab testing to assess levels of testosterone and other hormone-related parameters. The patterns and trends over time of multiple hormone levels, example free testosterone, total testosterone, and estradiol, inform the hormone replacement therapy dose and the adjustments. For many men taking aromatase inhibiting drugs and/or supplements in conjunction with testosterone replacement therapy, they may help to keep the estradiol levels in the optimum range between 20 to 40 picograms per milliliter. Testosterone replacement therapy in the context of prostate cancer is very controversial. Although testosterone replacement therapy does not appear to directly cause prostate cancer development, men at a high risk for prostate cancer should not undertake testosterone therapy without consulting a qualified healthcare provider. Testosterone therapy might benefit some men who have a history of prostate cancer, particularly those who have been successfully treated for low-risk disease and who have symptomatic androgen deficiency. But these men too should consult a healthcare provider before initiating a testosterone therapy. A man contemplating hormone replacement therapy should work closely with a qualified physician to plan a rational treatment approach that includes continued monitoring and screening. There's no one-size-fits-all treatment. Individuals vary, and hormone replacement requires careful attention to the signs and the symptoms, as well as the periodic lab testing. For men who choose not to, or who are advised not to, use hormone replacement therapy, nutrients can play a vital role in a comprehensive program designed to reduce the impact of aging on sex hormone production and metabolism. For more information about this, or more information on herbs, supplements, and natural treatment plans, check out my website.